Good evening, ladies and gentlemen, and welcome to Battling and Beating Cancer. And it's winter in Chicago, and there's traffic jams, and of course, we all have to show up in time for this live program to bring you the best information on cancer and beating the disease in all of its horrible forms. I'm Scott Seaman, and along with Charlene McMann, we're co-founders of Chicago Blood Cancer Foundation, a nonprofit committed and committing to curing lymphoma, leukemia, and myeloma, which are the blood cancers, and your co-host of Battling and Beating Cancer here on CAN TV Channel 21 in Chicago, and we are streaming live worldwide at chicagobloodcancer.org and at cantv.org/live. So we have a tremendous show for you tonight, because on this show we're going to talk about helping children who are battling blood cancer. And just to give you a little bit of a background, childhood cancers are the second leading cause of death of children, second only to accidents. And there are more than 60,000 kids in the United States that are cancer survivors, kids under the age 14 and under. And about 13,000 kids get diagnosed with cancer every year. And when we talk about blood cancer and the terrible effects of blood cancer, that's probably as true or more true for children, because 34% of the cases of cancer in children involve leukemias, 27% roughly involve brain and nervous system cancers, and 8% involve lymphoma. So 2 of the 3 major cancers in kids are blood cancers. Well, if you want to look, we talk on this show all the time about the importance of research, and research is paying off, and it's paying off for the benefit of kids as well as adults. Overall, the 5-year survival rate for kids has improved from roughly 50% before the 1970s to an overall rate for all the cancers combined of over 80%. And so what that translates into for children with blood cancer, the latest statistics, which span the period of 2001 through 2007, so they lag a little bit. 5-year survival rate for kids with Hodgkin lymphoma, 95%, 85% for non-Hodgkin lymphoma, and 83% for leukemias. And as I see, those statistics lag a little, so I think we're doing a little bit better than that today. Now, children diagnosed with cancer, and honey, I know this is an issue that touches at your heartstrings as it does all of us. There's nothing sadder than when you hear of a young boy or a young girl dying of blood cancer. You see it all the time on your Facebook and your internet groups.
Right, my internet organization.
And you just can't shake that. And when you see little kids struggling with cancer, it really pulls at you. When I was going through it and going through the treatment, feeling sorry for myself, Charlene and I would see a little baby or a little kid with cancer and say, my God, how horrible is that? And kids with cancer, there's some special considerations, because obviously due to their age and the treatments, they are at risk for secondary cancers. There's fertility issues and a host of other things. So it's extremely important that we put our kids in the hands of cancer doctors who are trained and specialized in treating cancer. And so while it's one of the saddest things to see a kid with cancer, you will find some of the most resourceful, the toughest, the best-spirited patients are these little guys and girls with cancer. I mean, they're truly amazing. They cope, I think, so much better a lot of times than their parents do.
Yes. Yeah.
So our guest tonight is Dr. John Cunningham. And Dr. Cunningham is the Professor of Pediatrics, the Chief of the Section of Pediatric Hematology, Oncology, and the Director of the Hematopoietic Stem Cell Transplantation Unit at the University of Chicago. And he's one of the internationally renowned experts on pediatric cancer and blood diseases. And he's developed some novel uses for stem cell transplants. And so we're going to get out of the way, because once again, we're doing our job here, Battling and Beating Cancer, of bringing you the best doctors to give you the best information. And these are the types of doctors that you should turn to when you or a family member are impacted by cancer. You can get the best, a doctor that knows their stuff, that's on top of the industry in terms of treatments, in terms of research, but who cares about you, cares about your family. So I'm going to step out of the way, and I'm going to turn it over to Charlene to talk to Dr. Cunningham about pediatric cancer.
Yes, and remember, you can reach us at chicagobloodcancer.org, or you can call us at 888-792-9992. Dr. Cunningham, thank you so much for joining us.
Thank you for having me.
Battling and Beating Cancer. I want to start out basically by talking about some of the symptoms of childhood leukemia that parents should be aware of.
So, first of all, I want to say that childhood leukemia is a very rare disease. Although it is the second leading cause of mortality or death in children, it is, as was mentioned earlier by Scott, there's only about 5,000 children in the United States every year who develop a blood cancer. However, there are some concerning signs. Usually, either the child develops an infection that they're not able to shake, and usually it's associated with a feeling of tiredness because they have a severe anemia, and frequently it's associated with bruising, usually noticing bruising that is unrelated to any kind of trauma. So in any of those instances, obviously the child should go to their pediatrician or to the family medicine doctor, and usually those individuals usually spot pretty quickly that this child has something that's out of the ordinary, that's not something like a regular infection, and refer them to a physician like myself.
Right. And basically, so we kind of, because a lot of kids get infections or they get colds or whatever, and they run fevers, but this is like consistent. This is something that just isn't going away.
This is not going away, and usually, as I say, it's an infection or something like that that's associated with another unusual sign in children, as I say, like severe anemia, bruising, or swelling of the child's lymph nodes, or a swelling in their abdomen.
And what kind of types of leukemias do you see in children? Because there are different ones in adults.
Right. So unlike adults, where the commonest cause of leukemia is acute myelogenous leukemia, in children the commonest cause of leukemia is acute lymphoblastic leukemia. And fortunately, most of those children, we can actually cure them with current day therapies. Acute lymphoblastic leukemia, as I say, usually as the symptoms are the three that I mentioned: infection, anemia, and bruising. But frequently those children also have swelling of the lymph nodes or swelling of the spleen associated with it as well.
And how do you diagnose when a parent brings their child in and these symptoms are there? How do you diagnose it?
In over 95% of children, by looking down the microscope at a blood smear, one can make the diagnosis of leukemia. But it requires sophisticated tests to actually identify precisely what type of leukemia it is, whether it's acute lymphoblastic leukemia, ALL, or acute myelogenous leukemia, AML, and that requires special tests of a bone marrow. So a bone marrow sample is usually obtained to make the precise diagnosis. The precise diagnosis is very critical because nowadays, with the complex array of treatments that we have, we can really tailor the treatment specifically to either ALL or AML and identify high rates of cure.
Traditionally, because we're dealing today versus years ago, what are the traditional treatments that you do today?
So over the last 30 years or so, the treatment of childhood leukemia has been a triumph for really American investment in cancer research. And over the last 30 years, we have developed a series of chemotherapies for ALL, that's acute lymphoblastic leukemia, that results in over 80% of children being cured with chemotherapy alone. In the context of acute myelogenous leukemia, which is AML, which is much rarer in children, unfortunately, about 50 to 60% of those children are cured, and about half of those children require a stem cell transplant as part of their treatment.
And that's the current treatment that you do now, as far as like the progress that we've made for years and years, right?
Right. So most children with ALL, they can be cured with chemotherapy alone, although about 15 to 20% of them still need a stem cell transplant to maximize their chance of cure. In the context of AML, about 50% of them will be cured with, or 50% of children will do well with chemotherapy alone, but the other 50% require a stem cell transplant to maximize the possibility of curing them.
And then tell us a little bit about the balancing of factors to maximize the effectiveness of the treatments. And minimize the risk of secondary cancers, which is a side effect sometimes of the drug therapies.
Right. Unfortunately, still 3 to 5% of children, just like in adults actually, develop secondary cancer. So one of the things that we are doing at the University of Chicago and in many other institutions is identifying which are the children who are at highest risk of developing those secondary cancers using genetic testing and using specific drugs that are not leukemia-inducing or secondary leukemia-inducing or second malignancy-inducing, and that's a very significant reason. That's a very significant change over the last 10 years. One of the specific areas that we are looking at the moment is, can we, in ALL, because we have such a high rate of cure, can we actually reduce the amount of chemotherapy we're giving? And the reason is to reduce both the risk of secondary cancers and the risk of long-term cardiac, poor cardiac outcomes, poor respiratory outcomes, and in fact poor cognitive outcomes. Because remember, some of these children who develop leukemia are in the 2 to 5 year range where the brain is still growing, and chemotherapy can actually damage that growing brain. So that's a very, very significant area of research for us at the moment.
And you mentioned, I wanted to go back for a moment, you mentioned briefly genetics, because are we getting more and more into genetics, like personalizing treatment for each individual, because everybody's different in how they...
So I've been taking care of kids with leukemia for about 30 years, and one of the most exciting things that is happening in the last 5 to 10 years is, and it's also happening, as you know, in adult leukemia, is the ability to use modern genetics and use the Genome Project to identify not just the standard AML and ALL groups, but actually subdivide these children into much smaller groups where we can actually tailor the therapy depending on the severity, the risk of relapse, etc. And I would predict that over the next 5 years, for instance, at our institution at the University of Chicago, we will probably sequence these leukemias when the child walks in the door, and we're beginning to do that now, so that we can actually tailor the therapy to increase the chance of cure, but also reduce the risk of secondary leukemias and reduce the risks of long-term fertility issues, long-term cardiac and cognitive problems.
And we also see in the blood cancer, we also see lymphomas in children. What types of lymphoma, because there's different types, of course. My husband had large B-cell, diffuse B-cell. And what types are you seeing in children?
So fortunately, given that diffuse B-cell lymphoma is actually can be very, very serious and lethal in some individuals, fortunately in children, the commonest kind of lymphoma is Hodgkin's lymphoma. And as was mentioned by Scott earlier, over 90% of children with Hodgkin's disease survive. Unfortunately, in those children who, the 10% who do not go into remission quickly, those children actually need either an autologous stem cell transplant or an allogeneic stem cell transplant to ensure long-term survival. But Hodgkin's disease is the commonest cause, usually in teenagers and young adults, and those lymphomas again respond very well to most of them respond very well to chemotherapy.
What symptoms do you see in lymphomas? Because my husband didn't really have any symptoms. He was asymptomatic, and it was kind of a shock to us. Right.
Well, in fact, frequently in parents with, say, a 12 or 14-year-old child, it can actually come up quite insidiously with just, inattention at school, associated with tiredness, and frequently just an occasional lymph node, which might be thought of to be mono or something like that, and in fact turns out to be a lymphoma. Again, these are rare diseases. Mono is very common, and Hodgkin's disease is. So obviously, seeing a health professional and a health professional who's thinking about these things and referring the appropriate physician if they think they have lymphoma. But the lymphoma symptoms are, when they do come on, are usually the major ones are similar to adults, where large lymph node swellings, swelling of the liver and spleen, and these things called B symptoms, where you have night sweats and weight loss. Those usually are pretty profound in children, just like they are in adults.
Right. And I mean, I've heard people, children and adults, they just wake up and they have all of a sudden they have just a lump on their neck, which is the lymph node,
Right.
and it just comes out of nowhere.
So, both leukemia and lymphoma in children tends to be a very rapid onset. It doesn't tend to be that, that you're waiting for 6-9 months. Like, I'm sure you've talked about follicular lymphoma in this
Right,
program,
right.
where, you can be, it's sort of an indolent disease where it can take 9-12 months before it really becomes obvious that there's a problem. Usually, both Hodgkin's disease and specifically non-Hodgkin's lymphoma, in children, is a very, very rapid disease. And in fact, there is a type of non-Hodgkin's lymphoma called Burkitt's lymphoma, which is very rare in children, but is truly a medical emergency in children if it is there, because you have to get the child into hospital and get them treated within 24 to 48 hours, because the side effects of the breakdown of the tumor cells can actually cause kidney failure and cause other problems that can actually take the child's life if not effectively treated.
Yeah, and I've heard another doctor say to me one time, he said, when you have this type of lymphoma, you need to be in the hospital or to a doctor last week.
Yes,
So
exactly. I think,
Yeah.
one of the things that I say to the young trainees in my program is, you don't sort of sit on things overnight. When a child comes into our institution, we're trying to make the diagnosis within a few hours, not within a few days of the child coming into hospital.
Right.
We're very fortunate to have the resources that we can usually tell what the child's diagnosis is within 24 hours of them actually being seen in the emergency room.
Doctor, you are a world leading expert on pediatric stem cell transplantation. So I wanted to talk a little bit about like traditional and the uses of stem cell transplants for children, because you did bring that up a couple times on stem cell transplantation.
So, as you know from this program, there are two types of transplantation: autologous stem cell transplantation, where you use the child's own stem cells, and there's allogeneic stem cell transplantation. In the context of blood cancers, really the only approach that is feasible in children with refractory or resistant disease is allogeneic stem cell transplant. Unfortunately, using the child's own normal stem cells is not a viable option in 2013. In the context of allogeneic stem cell transplant, about 1 in 4 children who require a transplant will have a sibling, and so given that we now have smaller families and frequently the child does not have a matched sibling or a brother or sister who's able to help them. About 30 to 50% of children who don't have a sibling will identify a donor in the National Marrow Donor Program registries. But given the complexity of the American population, and that we're all essentially come from many different parts of the world, frequently, especially if we have Latino heritage or African American heritage, there is there is not a donor that is suitable in the registry. So one of the areas that I have focused on in the last 15 years as a transplanter is trying to identify approaches that will allow every child to have a donor, and every adult, in fact, to have a donor. And one of the approaches that I have pioneered is the utilization of either brothers and sisters or mothers and fathers who are half matches, to actually use those as donors. And we've been very successful in actually utilizing them. So what I can say to any child or mother and father who come to me now is, we will have a donor for every single child. There's nobody we cannot transplant at this stage. And that's a very exciting option in comparison to say 10, 15 years ago, where perhaps up to 40% of children who required a transplant did not have what was called then a suitable donor.
Right, and they would literally die waiting.
And they would literally die
right,
because we would spend months and months,
waiting,
and you'd go into a child's clinic room and say, I'm sorry, we've done another round of the registry and we can't find donors. Now, I am a phenomenal advocate for the National Marrow Donor Program. That isn't say, I think that is still truly. We now have shown in our institution and in other institutions that if you have a matched unrelated donor, from the registry, it is equivalent to a matched sibling donor. In other words, the complications are essentially similar. But for those up to 60% of children who do not have do not have matched unrelated donor or sibling donor, now we can say we have donors for all of those children as well.
That's fantastic, really fantastic. Because we always waited in trying to match it and trying to get people, to really go out and donate,
And they should still,
Yes,
there are still
yes.
donor drives. In fact, we had one at our institution today, and it is really important. There are about 9 million people on the donor registry, particularly those who belong to select ethnic groups, as I say, like Latinos and African Americans. We really encourage them strongly to agree to be donors in the registry, because there are still differences in outcomes between somebody who has a matched sibling or a matched unrelated donor and those who have to use either a what we call haploidentical or parental donor, or use a cord blood transplant. Those results are still not as good. And we're making significant progress, but we still have a ways to go. So everybody should go out and actually
and
donate.
especially because we did a drive before, because one of our friend had passed away waiting for it because she's African American, and there aren't a lot of matches in that, so that's why we
less than 15% of African Americans who require a transplant have a donor, and I think it's something that I know has galvanized the African American community in Chicago to actually go out and participate in drives. But the more people that do this, the more likely there are to be donors.
Yeah, and I think it's good that you're pushing that, because I think people aren't aware of that. But what are some of the benefits associated with transplants? When they get a transplant, I mean, it kind of just starts your whole immune system over to some degree.
So I think there's two benefits. One is that obviously it is a way for us to replace the defective or the cancerous cancerous blood system with a new system. But the other thing is, many people used to think that the major effect of the transplant was that we were able to give more chemotherapy and therefore actually destroy more cells by higher chemotherapy. What we and others have shown is that over the last few years is, in fact, giving more chemotherapy actually is probably more likely to provide, to cause side effects. The actual new immune system that comes in actually goes out and seeks the leukemia cells or the lymphoma cells and actually destroys those cells. And that's what we call the graft versus leukemia or graft versus lymphoma effect. And that's a very, very important part of this, in fact, slight mismatch between either a brother, sister, or matched unrelated donor, or one of these parental transplants that we do. And so that's a very important effect, and it's an effect that we're now harnessing at the University of Chicago, where we have now got several people who are actually using ways to soup up those cells, to actually energize those cells even more, to reduce the risk of relapse after transplant. So in other words, we call that immunotherapy, and that immunotherapy is actually one of the next waves of things that we're actually doing at the university that I think will improve the outcomes for transplant.
And some of the other uses that you use for stem cell transplant.
So excitingly in children, the benefits from the investment that American people have put into transplantation have now also benefited children with the boy in the bubble that Paul Simon used to sing about, the immunodeficiencies, aplastic anemia, and metabolic storage diseases. These are areas that are now we're beginning to use stem cell transplant for very, very effectively. And so, one of the things I always talk to, again, my trainees and to parents about is that, stem cell transplant really is an effective therapy, not just for cancer, but we learned a lot about it from cancer, but now is being used for these other diseases like immunodeficiencies. And I think, I hope this is not too much of a prediction. I think in the next few years, for instance, diseases like sickle cell disease, where we're beginning to actually do transplantation on a regular basis, will become a large area for actually curing this disease, because we can now, for instance, cure sickle cell disease with transplantation. That was learned from a young woman, in fact, who had both acute myelogenous leukemia and sickle cell disease, and she was cured of both diseases.
Wow. Some of the improvements that we have seen in recent years in terms of making stem cell transplant more effective and reducing some of the side effects. What would you say is the difference now?
Well, one of the areas that everybody who has heard of a stem cell transplant from somebody else is that they worry about rejection, and they worry about graft versus host disease. I think the risk of rejection now, which used to be for some of these mismatch type of transplants, was in the 5 to 10% range. Now, with some of the approaches that we use, for instance, we actually mix in adults parental cells and cord blood cells together, and that's reduced the risk of that kind of transplant, rejection in that kind of transplant, from over 5% to less than 1% now. So that means, in real terms, that less than 1 in 100 children or less than 1 in 100 adults who have a transplant risk rejection. Graft versus host disease used to be, when I started doing transplant, 70-80% of people would develop very severe graft versus host disease, which, as many of your viewers will know, is related to severe skin rashes, liver failure, very severe diarrhea, and used to be lethal in maybe 30 to 50% of patients. Now less than 10% of people will die of graft versus host disease, and now we have probably up to 20 different treatments for graft versus host disease, and many of them are highly effective. So graft versus host disease is becoming less of a problem, and in fact we're beginning to harness graft versus host disease for this thing called graft versus leukemia effect. So in other words, instead of it being a problem, we're trying to turn it into actually a weapon to actually take out the leukemic cells.
Wow. We got to start wrapping it up now, but I wanted to ask you if you could just tell us some of the exciting projects that you're working on now.
So as I mentioned earlier, I think the most exciting thing that is happening in leukemia at the moment, or one of the the two things that are most exciting, are one, the development of small molecules that are using the genetics that we are now understanding about leukemia to target specific leukemias. The second area, I think, is this development of immunotherapeutics. In other words, using the stem cell graft as a weapon to actually destroy the leukemia cells themselves, the residual leukemia cells that exist at the time of transplant.
And I guess, we have to wrap it up, but what are some of the tips that we could give, for important things for children with cancer and so their parents would know?
I think the major things I would say is that unlike 20 years ago, if you go to an outstanding institution that has got all the tools available to take care of cancer, that children with cancer, over 80% of them are cured of their disease.
Wow.
And so that is a very exciting thing to be able to say to parents. Unfortunately, I would say to all the other to viewers though as well that unfortunately, cancer still is a significant cause. Resistant cancer is still a significant cause of childhood mortality, and we still need to do significant research so that no child with cancer is not a survivor, and that's our goal.
Right, and like Scott said before, I'm still seeing children dying as you are every day.
Right.
So it's still, we're still not there yet, but we're getting close.
Absolutely.
Dr. Cunningham, thank you so much for joining us on Battling and Beating Cancer. And I want you to join us next Thursday night at 7:30 p.m. for another episode of Chicago Blood Cancer Foundation Battling and Beating Cancer on CAN TV. 21, Dr. Gordon and Dr. Thaxton of Northwestern will be with us to discuss their exciting research regarding gold nanoparticles. On behalf of Scott and myself, I want to thank you and our executive directors, Christy and Dorothy, and good night, and thank you so much for joining us.